Hello and welcome to another episode of the Health Notebook. Today we are discussing laboratory issues, and the whole idea is just to make the viewers accustomed to some of the activities that actually go in and behind the laboratory when your blood sample is taken. We've got Miss Fatima Isaacs in the studio, and she's a lab technician, and she'll be giving us some insight in terms of activities when the blood sample arrives and when it goes into the laboratory. Fatima Isaacs, welcome to the studio.
Thank you.
Okay. Can you maybe just tell us a little bit about yourself?
So I studied at Peninsula Technicon, and then I went on to do my in-service training at Greenpoint SIMR then. Went to Alexander Bay, worked at Alex School, came back, worked at Pasquet, and I went to Saudi Arabia for 5 years, worked in a laboratory in serology. Came back to South Africa and I decided I wanted to do research. And then I went into research, but it's not my thing. I stayed there for about 2 years. And then I discovered another lab and I came back into ClinPath.
Okay, so you seem to have a broad range of experience, and now in terms of your laboratory experience, how many years have you actually been working in the laboratory now?
I've been in the lab since 1997.
Okay. So you've been there for quite some time, yeah. And you probably know the ins and outs of the laboratory and things like that. So today the whole idea is just to give the viewers some idea in terms of different types of tests. So when they go and see a medical practitioner, the medical practitioner would then obviously take a blood sample or request a blood sample. But most people don't really understand what actually happens from that particular time, from that moment when the blood is actually taken, and what is the actual process that goes on within the lab. Now, as you've mentioned to the viewers, that you're a lab technician. So just explain the lab technician and what's the functions of a lab technician in case any of the viewers are interested in becoming a lab technician as well.
Okay, so just as a correction, we've got lab technicians and then we've got lab technologists, right? Okay. So the technician would be the person who just does the assays, and the technologist would then be the more qualified, which we have lab technologists. Okay. Technicians are in-house trained, but technologists goes and study at an institute.
Okay. You've mentioned assays. Can you just explain to the viewers what does an assay mean?
So the assays are basically the test which is requested by the clinician. Okay. It would be if you're doing a diabetes screen, we test for glucose, okay. Main thing, right? Okay. The assays is varied. It can be glucose, it can be the sodium potassium chlorides, it can be a full blood count which consists of hemoglobin, which like part of the iron study. It could be the white cell count as a infectious marker, and then also the different types of white cells we also analyze, depending. Yeah.
Now in terms of lab technicians, you, just like a medical practitioner, would have different sub-disciplines in terms of surgery and dermatology that deal with different aspects of the human body. Now, in terms of laboratory functions, are there sub-disciplines where a lab technician might also function in certain areas? And if you can maybe give an example of one or two of the common stuff.
Okay, so we've got different disciplines. Okay. As a clinical pathology laboratory, it would consist basically of biochemistry or chemistry.
So when you mean biochemistry, what would you, if you could just explain to the viewers, what would the test be, the typical common test?
Then the common test in biochemistry would be your UNEs and your LFTs.
So the UNE would be your kidney function. Kidney so function. If the medical practitioner is suspecting a medical illness related or something that might affect the kidneys, then he would request a UNE, which is the ureum and the creatinine, which measures the kidney function.
Yes, and then also sodium potassium chloride, which goes with that, mostly sodium and potassium, okay, for excretion purposes, right? And then we have the LFTs, which is more the liver. Okay. That would be the liver function test. Okay. It consists of your total proteins, your bilirubins, your different enzymes, which is your AST, your ALT, your ALP, which is all enzymes of the liver. And it would give you it would give the clinician an indication of what's going on in the liver. Has this patient got hepatitis? Has the patient got some liver condition? That it's all of our tests basically are there to assist the clinician with their diagnosis, basically.
Okay, so you've mentioned the chemistry functions and you've given the viewers some examples. Now, in terms of other functions, I mean, what other tests would you perform?
Within biochemistry or the other disciplines?
Within the other disciplines.
Okay, so then we have hematology. Hematology is where we do tests on whole blood, as opposed to chemistry. Chemistry is where we centrifuge the blood and we only take the clear part, which is either serum or plasma, depending on what's in the tube. But hematology, we'd only basically use whole blood, and this is to test for the red blood cells. We want to count how many red blood cells there are in a patient's system of blood. We want to see if they've got a low red blood cell or a high red blood cell. And then using the red blood cells, we would also then determine the hemoglobin, which in conjunction with chemistry would then give the clinician an idea if the patient is iron deficient or not.
So in simple terms, it would mean that you would be, just to explain to the viewers, that would be assessing you for anemia.
Yes.
Okay. So now, other aspects, so you've mentioned the hematology, you've mentioned aspects related to kidney function. What other aspects are there in the laboratory that you can just inform the viewers about?
Then we have microbiology, which is maybe the most interesting, because microbiology is where they take certain fluids or sometimes blood itself or urine, feces, and they culture it in order to determine whether it's infected with bacteria. This bacteria is then cultured it normally takes about 18 hours. The next day they would then determine if it's there or not. And so from there they would be able to tell you if it's sensitive to certain antibiotics. They would tell the clinician, yes, the bacteria is present, and they would tell the clinician which bacteria it is, and then also which antibiotics can be used to treat the specific bacteria or infection.
So just to put the viewers into perspective, you've mentioned all the different types of fluid. It can be blood, it can be urine, it can be feces as well. So then it comes to the laboratory. Can you just explain a little bit about the process? Now you receive the sample. Explain to the viewers, where does it grow and things like that, and do you measure it every day, or how do you evaluate it? I think they might be a little bit curious to determine how do you actually grow the bacteria in the laboratory as well.
Okay, so when we receive the sample, all samples, whether it goes to any of those disciplines, has to pass our sample reception area first.
Okay.
For traceability purposes, we prefer receiving it, so we date and timestamp the request form. We put a specific unique number on both the sample and on the request form. We enter it into the system, and then so for purposes of traceability, so we know when the sample came in, who sent the sample, which sample was sent, right? So then it would go to the lab, and it would go microbiology specifically. If it was a urine and the doctor or the clinician would be suspecting cystitis, for instance, example.
Which is a bladder infection?
Which is a bladder infection.
Okay.
They would send it to the laboratory, the urine. We would do a dipstick on it. Then we would the dipstick basically would tell us if there are leukocytes in the sample, ketones.
Signs of infection.
Yes, all signs of infection. And then this dipstick has got a little marker on called the nitrate marker. Okay. So if this is positive, we basically have an idea of what type of bacteria it could be as well. It's just a help. We then culture the sample on a specific media.
So in terms of just explain to the viewers, the culture actually means growing it.
Yes, first not growing, we would inoculate the media, meaning we would take a specific volume of the urine. There's a specific loop with a specific hole or a specific volume marker. We would then inoculate the media.
Okay, so you place it on the media.
Place it on the media, and we streak it out, meaning we try and we want eventually to have single colonies, right?
Okay.
So that would help us with identification of
the difference. So after it's grown, after a number of days, and you suspect is this particular bacteria, obviously you'll also then evaluate it a little bit further. So if you could just explain to the viewers.
So after 18 or the next morning, we would then take the sample, take it out of the incubator, because we incubate it at basically body temperature, 37 degrees Celsius, right?
So you replicate the human system in a specific environment so that this bacteria is allowed to grow?
Yes. So we'd put it in an incubator. The next morning, come back, take it out. We'd then see if there was bacterium. So if it was, example, E. coli, it would have a specific color on because the medium that we inoculate has indicators in it, color indicators. So the E. coli will basically be pinkish. So then we have an idea, but then again, Klebsiella could also be pink.
So these are all these fancy names that you're mentioning.
It's bacteria names.
Those are actually bacteria.
Yes. So then we would take this, because now we can't like just say yes, it is E. coli, right? So then we would take some of this or growth. We would then put it into an instrument. It's the new method now. We don't do sugars. Before we used to have a rack, and we used to have different types of color sugars and stuff. But now we put it into an instrument, and the next day the instrument will give us an exact identification for the bacteria. It will also tell us, or it will give us an indication of which antibiotics can be used in order to treat this patient for this bacteria. And it gives you a panel or lots of antibiotics from which the clinician can then choose, because we don't know what the patient is allergic for or not, right? So we wouldn't only give one antibiotic, so they can like decide which of the antibiotics they would like to use on the patient.
Okay, I mean, so that actually puts it into perspective from the viewer's side, because when they receive the laboratory report, I mean, there's a list of medications and it aids the medical practitioner to decide on it. So there's a lot of work that is being done besides that paper that people would normally take for granted as well. So you're actually one of those people that do extensive work behind the scene to make sure that they receive the correct treatment based on what their culture provides.
Yeah, so basically we'd also do screening tests for them, because the clinician would then maybe have patients coming in and saying, you know what, I've got a family history of diabetes. And we would then say, okay, they would send a sample, and we would then aid them in screening these patients and knowing if they have diabetes, if they're already at that stage of being diabetic, or if they have a chance of being diabetic, you know, pre-diabetic diabetes. And then also there are the biochemistry. On the biochemistry side, we have the cancer markers that we can look for, certain cancer markers which we offer. We have the cholesterol, which is a common hyperlipidemia.
Okay. Now I know you've given some examples where you either add value by screening, you can aid the diagnosis as well. I'm going to say that again. Sorry, man. Okay, so you've given us some examples now where you show your value by either assisting the medical practitioner by allowing him to make the correct decision, by providing screening, and also to aid the diagnosis as well. Now, there's something very important which I actually forgot to ask you about, which is quite common in South Africa and especially the Western Cape, in terms of TB and the microbiology. Regarding TB, I know when a patient comes and sees me, I would recommend or I would request them to provide samples of saliva and sputum, so that so we'll just take that again. Sorry, man. Yeah, so when a patient actually comes and see me, I would actually request the patient to provide a sample of sputum. Just explain to the viewers then what's the process that happens in the laboratory after receiving that, and what tests are available, and what is the turnaround time for actually excluding tuberculosis.
Okay. We've got a new method now called the Gene Expert.
Okay.
The Gene Expert is, it's got a turnaround time, or it's got a processing time of about 4 hours, which as opposed to previously it used to be, I think, a few weeks, 6 weeks or something, where we used to culture it. We still do use the culture method, although the Gene Expert is much faster. So it's a sputum that we require, and then with processing the sputum, we put it in a machine, and about 4 hours later we would then have a definite result on whether the patient has actually got tuberculosis or not. Yes, it's just basically sputum. We sometimes do request 2 samples just as confirmation, because you don't want to have a negative and the patient's actually positive, because you know what, you sometimes have the sputum but it's not a good sample.
Yeah.
or you have a positive, but you want to make sure that it is really, positives are easy. If it's there, it's there.
Okay.
Negatives basically could have been a bad sample, so you need to kind of confirm and make sure that the second sample maybe was taken better. And that is why we would request.
The number of samples is there also to confirm it or to exclude it as well. So also just to inform the viewers, sometimes the tuberculosis can actually present with fever, weight loss and night sweats, which are your symptoms, and sometimes that sputum might even come back negative, and then the medical practitioner needs to investigate the individual further and identify other areas where they might suspect that tuberculosis may be involved in. Now let's go a little bit to something a little bit more common. I know you've mentioned diabetes. Can you just run through some of the tests available for diabetes, the pre-diabetic as well as the diabetic as well?
Okay, so with diabetes, we basically look for, or we test for glucose.
Okay.
But we have the HbA1c as well, which can be a monitoring test, right?
Okay.
So
what does this actually do?
Yes.
HbA1c?
So the HbA1c tests the red blood cell. We know that basically a red blood cell has a lifespan of 21 days. So it has a record of 21 days.
Okay.
So what happens is we lyse this red blood cell and we see what's been going on. Like, it's like looking back into the past kind of thing. So yes, if people think that, with diabetic people, their glucose are normal or it's where it should be, but then the HbA1c would actually show up, no, this person has been naughty for the last 21 days. The clinician can see where the patient really sits within his diagnosis.
Okay.
By doing the HbA1c.
Sort of a memory effect. Okay.
Yes. The glucose, because we use the WHO guidelines for determination of diabetes, right? So we prefer fasting glucose.
So when you mean fasting, just explain to the viewers.
Yes. So we've got a fasting. We would like a minimum fasting period of 8 hours for diabetic testing, for the glucose testing, and it's not like fasting where you eat nothing for the day or for the 8 hours. We would also prefer the patient drinking water, because this would then prevent dehydration, which then have the hemo concentration, which would give you a false reading, right? Okay. So water for the 8 hours, but nothing else which has calorie content.
Okay.
Do you understand
Yes.
what I mean? So then for that 8 hours, they would be fasting. They would come in. The clinician would take the sample and would send it off to the laboratory. Goes through the sample processing, whereby we test for glucose.
Okay.
And then depending on the result, right, we have a normal range, and then we have a range where we have that intermediate range where we're not sure, is this patient actually diabetic or not. So then, because remember, we're individuals, yes, we've got a normal range, but it might not be normal for you. Okay. So then what we do is the glucose tolerance test. The patient, the clinician would ask the patient to come for a glucose tolerance test, where the patient has fasted for 8 hours. They take a sample, a fasting sample, and then the clinician gives the patient a glucose solution.
Okay.
And then for a period of 2 hours, every hour he takes the sample from the patient, and then he sends it off to the laboratory, and it has to follow a certain trend by which then the clinician would be able to determine if the patient is diabetic, if his body is actually utilizing this glucose like it should or not.
Okay, so just also to explain to the viewers, then there is international guidelines which define in what range your value should be, and then there is a range in terms of classifying you as a pre-diabetic and then classifying you as a diabetic. Can you just elaborate in terms of how much should your readings be when you are classified as a diabetic?
We would prefer it to be 6 and below. Okay. for normal, 6.1 max, right? And then some would say 4 and some would say 3, depending on what your laboratory ranges are. Anything between 6 and maybe 7, we'd say, oh, that's an indeterminate range, and then above that, we would say this patient might definitely be a diabetic.
Okay. Now, in terms of measuring your cholesterol, just touch on that as well. So, firstly, the 2 methods of assessing the cholesterol. So, if you could just highlight those 2 methods.
Cholesterol, we do the lipo program, or the profile or the lipid profile, depending what the clinician asks, of course. So the lipid profile, we basically want to know what the two main lipids are doing, and those are the cholesterol and the triglycerides, right? In excess, if there's an excess of cholesterol, it's bad. Sorry, if there's an excess of triglycerides, it's bad. So then we also do an HDL. The HDL is the good.
Can I just interrupt you there? So just so that the viewers understand, can you maybe just give them an overview of the different components of the lipogram or the lipid profile, so that they understand exactly what is it made up of when you actually do the test?
So the cholesterol is required for membrane formation, like building of membranes, and then also for steroid hormonal construction or building, right, if you want. The triglycerides, like I said, is that main, or is one of the forms in which the body stores energy, right? So we need this. It goes into the fat cells and it's stored as a triglyceride. But too much is not good. The cholesterol, too much cholesterol would then go and sit on the insides of our arteries, and it starts clogging the arteries. The too much triglycerides is a factor in cardiac heart failure.
Okay, so those are the components which then make up your lipid profile. And then just to inform the viewers, how would they see it on the laboratory form?
Then we would have another component, which is the HDL, which is a good lipid. It's good because it carries the cholesterol out of the system, and it goes and takes it to the liver, so it can be kind of excreted. When we give the report, we would then give on the report the cholesterol, the total cholesterol level, the triglycerides, and then the HDL, and from that we would calculate the LDL, which is the bad lipid, because it's bad because it carries, it's concentrated with cholesterol. And then there are other ratios which the doctors don't, or the clinicians don't really worry about, as long as they have the triglycerides, the cholesterol, the HDL and the LDL results. They can then determine where the patient sits within the hyperlipidemia.
And then obviously, if need be, the medical practitioner would prescribe medication.
Yes, depending on the results, and as well as I'm not sure what the clinician does, but from our side we would sometimes repeat the assay a few weeks later, just to make sure that it wasn't because the patient didn't fast properly. Because for hyperlipidemia, I forgot to say, we would want the patient to fast for at least 12 hours. And the same way as for diabetes, we would want them to fast, not just by staying away from food, but also like drinking water. This is to prevent, like I said, the hemo concentration, which would then affect our results in the lab.
Okay, so we've reached the end of the show. Can you maybe just give the viewers one or two take-home messages in terms of the role of the value that the laboratory technician can add, and in terms of some advice when taking blood samples? So if you can maybe just give the viewers one or two tips.
Okay, so taking of the blood samples, many of our our assay or the result that we receive, it depends on the type of sample that we receive. Meaning, if the sample is hemolyzed, we're not going to get a good result. So the quality of sample determines the quality of result, right? And that includes the fasting. Has the patient fasted for the minimum period required? Because it will, in the end, it will affect the type of result that you get. So that is sometimes why we repeat assays a few weeks later, because we then want to make sure that the patient actually did follow what they were supposed to be doing. And then, yes, we are laboratory technologists. We really, at least I enjoy my job. We don't really see the patients physically. It's very rarely that we come into contact with them, but for us, that is not only a number, because working in a hospital, you tend to then also know the person by name, and you follow what's going on, and you
by the different tests and things like that.
Yeah, not only the tests, but sometimes we can see the trend that the result takes.
Okay.
even if it's an outside patient. We tend to, at least most of us, we tend to see what the previous results was, to see if it fits in with what's going on now.
So you do a bit of analysis as well.
Yes, we always, most of our assay, before we release our results, we like checking to see what the previous result was, to see then if this patient is, because sometimes you have a hemoglobin which is low, but is this patient somebody who's anemic? So has he had a history of anemia, or is this now a new thing? So it helps us as well to know where we sit. If the potassium is raised, why is it raised? Is it raised because the sample wasn't good? Was it hemolyzed? Or is it raised because the patient is actually the sample wasn't transported correctly?
So there's various aspects that can go wrong, and one can actually end up with a false positive result.
Yes, or a bad result. So you before releasing, we actually have to check.
Verify it, So, Miss Fatima Isaacs, it's been a great pleasure having you in the studio.
Thanks for having me on this program.
So there you have it. There is a lot of effort and a lot of work that actually takes place when one actually receives the laboratory report. And now you've actually heard firsthand from a person that actually works in the laboratory. And the most important thing here is also to adhere to what your medical practitioner would advise. So if he requests you to actually fast and have your bloods taken as a fasting blood sample, it's very important to actually comply with that, so that it can actually add value by confirming or excluding a particular illness. So once again, thank you very much for watching. Stay tuned for another episode, same time, same place, next week.